Good job, I'm very happy. No, you're still not happy? You'll be happy in April. This is supposed to work. April. Okay. Just making sure my stuff works today. Okay, so good morning. Today we're going to talk about aortic dissections. Is this too loud? Okay. And aortic syndromes. It's a very exciting topic because it's something that we have to intervene and do something extraordinary immediately, or else the patient could die. Somebody tell me the difference between aortic dissection and aortic aneurysm. Okay, aneurysm is an outpouching or a dilatation of the artery, right? Whereas dissection is it's actually starting to leak, right? It's causing a false lumen. It's an intimal wall tear. And where do dissections occur? When we hear the term aortic dissection, where are we talking about? Generally, we're talking about the chest area. When we talk about aortic aneurysms, where are we generally referring to? Abdominal area. All right, and in old people, it's usually infrarenal. So that old person that comes in with hypotension and flank pain, that's aortic aneurysm. And can they dissect? Sure. But in general, when we use the terminology aortic dissection, we're referring to the chest. Okay? I don't know why I'm echoing. I don't know what's happening up in here. Okay. All right, so we're going to talk about that. All right. Maybe. Okay, as usual, we use Tentelli as our reference. And here are some of the things we're going to talk about. Kind of epidemiology, pathophys, clinical evaluation. How do we treat? Like, what do we need to do? No kidding, like right away. And then what do we do with these patients afterwards? All right, seems pretty straightforward. Okay, let's do a warm-up case. Can you guys read it yourselves? I think you can. I believe in you.
You're the only one.
Okay, I think I give you enough time. All right. Vital signs. What do we think about those vital signs right away? Are vital signs vital? What's wrong with these particular vital signs? Severely hypertense, right? And heart rate's 92. All right. Temperature's okay. Respiratory rate a little high, but nothing crazy, right? We're not going to like throw a tube down their throat for that. What's your safety net? We're talking about the emergency department. You're an ERPA. I can't stand here. Apparently, he wants me to stay put. He doesn't want me to walk around. Is EMED your next exam? What's next? Is it Friday?
Yes.
Okay. Oh yeah, I remember that because Thursdays are review. Okay. All right. What's our safety net? I'm sorry. IVO2 monitor on everybody. What kind of labs are we going to do on a patient that presents like this? And what's our differential? Let's ask that. What's our differential? It is an aortic dissection lecture, so aortic dissection, very good. Very astute. What else? MI. What's the top three that I said that we have to work up that we need to consider? PE. Those are the three that we have to work up. There's three others that we can rule out right away. What are those? Tension pneumo, tamponade, and Borhaus. Very good. You guys nailed it. Okay? All right. So knowing that our top three differentials that require a workup are PE, acute coronary syndrome, and dissection, what labs do we need to do? Yeah, I got to do a trope. Got to do, maybe you would consider a D-dimer in this patient. What else? CBC chemistry. Why is that? Maybe some coags? Why coags? If it's dissecting or losing blood, we're probably going to have to transfuse them, right? A lot of times we'll even activate a massive transfusion protocol because these people are going to lose a lot of blood. Okay, what else? What diagnostic tests do we need to do? I'm sorry? CT chest, and I will tell you that the technical term, if you suspect dissection, is CT angiogram, also, but specifically aortogram, which is different than a CT angiogram PE study. They're both kind of blatantly called the CT angiogram, but they're distinctly different. If you're looking at the aorta, you have to do an aortogram. If you're doing a PE study, you have to do a PE study. They're different. Even though luckily we can see both with either, but they're very dedicated studies. And the reason why is that a PE study will go only from one part of the trachea to the bottom of the lungs, whereas an aorta study will get all the way down to the iliacs. Okay, so it's distinctly different. But if you're having a like aortic knob, for instance, dissection, you will also see that on your CTPE protocol. But it has to be contrasted studies. You with me? Okay, let's do this. All right. We're going to talk about differentials. What other diagnostics can we do? What does everybody with chest pain get? ECG, good, within 10 minutes. What else? Okay, if they need it, they might need some oxygen. What else does everybody get that has chest pain? Maybe. We're talking about diagnostic studies. Chest x-ray, they do a portable chest. Okay, good. You guys, awesome. So if somebody's an extremist, we're gonna do IVO2 monitor, we're gonna support their airway and breathing, make sure their airway is patent, make sure the breathing is supported. Can they have respiratory distress with aortic dissection? Yeah, it can dissect into the left cavity or left chest and they can have a sudden pleural infusion and dyspnea. They can also dissect into the coronary arteries and present with a giant, massive inferior MI with hypotension and cardiogenic shock. So we want to support airway, breathing, circulation. I'm going to tell you guys this at the beginning, so in case you drown me out the rest of the time because you're looking at surgery or whatever, or just something happened to you, you're exhausted because you've been up since 2 a.m. studying or whatever your work ethic is. What we are going for in somebody that has dissection is we're aiming for a heart rate of 60 and a systolic pressure of 120. Those are our goals. There's a range, you can do 60 to 80 or 120 to 130 systolic, but the overall goal is a heart rate of 60 and a systolic pressure of 120. So from what you've learned in the past about hypertensive urgency and emergency, how much are you supposed to reduce the blood pressure in those people? 25%. When we're talking about dissection, that does not apply. You are aiming for a systolic pressure of 120. So if they came in with a systolic pressure of 240, you're dropping it to 120, and that's okay. All right, that's what we want. All right, I want you to remember that. The other thing I want you to remember is that almost always we do a 2-drug strategy, starting with the beta blocker. We have to control the rate, then we vasodilate. That's the order. If you screw up and vasodilate first, you will drop their pressure, but you'll also increase their shear force and they will die. You will kill them, okay? Control the rate, then vasodilate, all right? And then say it all up front. What's our goal, systolic pressure? Our heart rate? And which medicine are we gonna start with first? Beta blocker followed by a nitrate. Okay, it's a 2-drug strategy. We're gonna control the rate first. That means we gotta get the rate to 60, and if the pressure is still high, then we will add the nitrate. What if they have a contraindication to a beta blocker? We're gonna do a calcium channel blocker, and it's gonna be a very special one. We're gonna talk about that. Okay, and then of course, urgent surgical consultation. All right, good. So what is it? Okay, so it's a life-threatening event. That's why I'm being so serious up here, okay? Because it's life-threatening, and what we do in the first few minutes of this matters, okay? So aortic syndromes or emergencies include dissection, which we talked about. We talked about aneurysm, which are in 2 different locations, but same disease process. It's just that different populations of people get these differently, and I'll talk about that in a moment. Other things that are still under this giant umbrella are things like atherosclerotic ulcer, as well as an intramural hematoma, which are all kind of phases of things that happen before they dissect, okay? It says here, acute aortic syndromes are uncommon, very hard to diagnose, and are frequently fatal, with a 57% 10-year survival rate. So basically, this is one of those diagnoses that we're meant to miss and think something else is going on. I told you the story of this lady who had chest pain, and I just knew she had a PE because she was having some respiratory issues or whatever. I did a CTPE protocol, and it came back a small dissection, and I remember I joked, I was like, nailed it, but it's because I picked it up and didn't miss it, but it was by accident. So, strong index of suspicion, and just another little clue here at the beginning of this lecture for you to remember, besides the systolic pressure, heart rate, and if you think it's dissection, they have a very classic story, kind of like our warm-up case. But I want you to think about dissection as the chest pain and something else. Chest pain and leg weakness. Chest pain and syncope. Chest pain and Horner syndrome or hoarseness. Chest pain and stroke. 30% of these people will have a CVA. Why? Why will they present with a stroke?
Because you're creating pain, so it's going to have protocol.
Anything downstream from wherever that dissection is not getting perfused. So a lot of times if it's happening on the aortic arch, branches of the carotid arteries are coming off that arch. So guess what? The brain's not getting perfused. They present with stroke-like symptoms. Full one-sided body weakness, facial droop, whatever. So remember dissection as the chest pain and something neurologic or and something else, all right? Very fatal. All right. When do we think that it occurs? Who gets dissections or aortic syndromes? When I talk about aneurysm in the belly, who gets those? Old people, okay? Much older than me, just to be clear, okay? Okay, old people. And then what are their underlying comorbidities? Hypertension, hyperlipidemia, coronary artery disease, what else? Diabetes, right? All this stuff. Or people who've had like chronic alcoholics, chronic methamphetamine users, those are people at risk, right? And believe it or not, fluoroquinolones have been implemented in dissections, okay? All right, prior cardiac surgery is also a risk factor. Why is that? Yeah, I mean, you got remodeling, there's weakening of the vessel, all kinds of things like that. And believe it or not, in younger people, pregnancy, young women, it increases their risk of dissection by like 4-fold. Again, a lot of things that are happening to women when they carry you people as babies, okay? We were all there once. All right, so there are different pathologies that occur maybe we say in the same location. They're kind of the same pathology in different locations, so you can say that one of two ways, but one is distinctly different and more life-threatening, okay? When we turn, just to remind you, when we talk about dissection, by and large, most of us are referring to the thoracic cavity. When we talk about aneurysms, we're almost always talking about the belly and infrarenal areas. And then dissections are further classified into Stanford A or B. And we're going to talk about that in a moment. If they're Stanford A, they always need surgical consultation. So dissection itself happens after the intima allows blood to enter and dissect between the intimal and adventitial layers. It happens more often in men greater than women, blacks greater than whites, greater than Asian, okay? Most of the ascending aorta. And what time of year and what time of morning, just guessing, do you think that these more often recur or occur? Not recur, because really it doesn't recur very often, right? They usually don't, they're usually fatal, but give me a month of the year that you think this happens in. Close, January. You said December, January. And what time of the morning, or day, sorry. Morning, 6 to 9 a.m. Okay, 6 to 9 a.m. Isn't that weird? January, 6 to 9 a.m. So if you make it to February and you're old and you have all those risk factors, you're crushing life. All right. All right, so it does have a bimodal age distribution, believe it or not. We see it in old people, right? We see it in those old people, like greater than 50 with hypertension and ischemic heart disease, the stupid thing. And then who else do we see it in? Young 30-year-olds people. Some of them are because of Marfans. Some of them are because of just bad genetics, right? Some of them are bad luck. Some of them are because they've maybe abused cocaine or something. Maybe some of them are because fluoroquinolones, which also can affect your Achilles tendon and connective tissues, have also been implemented. It's kind of crazy, right? Have you guys ever heard of that? Yeah, so I'm very careful about who I give fluoroquinolones to, and it's kind of like rolling the dice. But anyway, but some, the others, of course, the over 50 people with ischemic heart disease and hypertension. So you guys have heard of this classification before, Stanford and DeBakey. Are you guys talking about this right now in surgery? Yeah, so most of the time we use the Stanford classification, and it's just easier. It's either A or B. And then DeBakey has 3 types. Okay, so here's a cartoon of what those look like. Stanford A basically just means anything that involves the ascending or arch of the aorta, and type B is only the descending aorta. And why does that matter? Yeah, if it's an A and it involves the ascending or the arch at all, that's a surgical consultation, that's a surgical emergency. If it's descending all the way down into the infrarenals here, which is the infrarenals or the iliacs, how do we manage that? Blood pressure control is usually medical management. These older people that have all these comorbidities, they don't want to do surgery on them, okay? They just want to medically manage them, okay? So that's the difference. Type A involves arch or the ascending aorta, B is descending. Okay, so what are some clinical features? How do these patients present? How did our warm-up case present? Is that pretty classic presentation? Ripping, tearing, chest pain. Is it gradual or sudden? Sudden onset. Remember, sudden onset, bad. Sudden onset, tearing, ripping, chest pain, radiates to the back. So that's a aortic dissection until proven otherwise. But what else are we looking for? Remember I said it's a chest pain and we're looking for some sort of neurological deficits. So right away I'm checking radial pulse, radiofemoral pulse. We're checking for pulse discriminations because depending on which side it's happening, there'll be a blood pressure and pulse discrimination. That should be your next clue. Plus they're getting their ECG, which can be misleading because it can show you an inferior MI and you just think, hey, it's an MI. You give them nitrates, you've killed them. It's scary. It's scary stuff. So anybody who presents with chest pain, I think it's an MI. I'm doing their radial stuff. I'm looking real quick at their belly, at their aorta, just to see if maybe their abdominal aorta is enlarged. You can't really see the thoracic aorta on the bedside ultrasound. But I'm also looking for pulmonary, like a pericardial infusion, just real quick before I make any decisions about nitrates or beta blockers, okay? Usually these people feel like they're gonna die. They feel like their vessel and their chest just ripped. They come in, their eyeballs are big, they know they have that fear of impending doom, and they describe the pain as the worst that they've ever felt. Half the time they'll say it's ripping or tearing. That's gotta be pretty scary, right? Okay, 64% say sudden onset, very sharp pain. 50% says it's tearing or ripping. Okay, most of the time, and I guess in 464 dissections in a particular study, 60% had anterior chest pain in the Stanford type A. If somebody has a Stanford type B aneurysm of the tummy, how do they present? Abdominal pain, right? If they're diabetic, they may not. They may just be the old lady that comes in from the nursing facility with syncope, and you're gonna have to do a bedside ultrasound of their abdominal aorta and make sure it's not enlarged greater than 3 centimeters. 3 centimeters or less should be fairly normal. In some literature it says 2 centimeters. What does surgery teach you? Okay. You would get taught. Okay. The gist is that if it's greater than 3, it should be abnormal. So we get some clues. The other thing is that most of the time the abdominal aneurysms, they present with flank pain. So don't be misleading and think, oh, this is pyelo. Sometimes they'll even have the nerve and audacity to have hematuria in their urine. And why is that? If they're having an aneurysm of their infrarenal artery, why would they have hematuria? It's abutting the ureter, irritating it, causing hematuria. You know what else they can present with? Hydronephrosis. Because the big mass from the infrarenal aorta is literally pressing and having a mass effect on the ureter. So just to make it more confusing and challenging for us, this is why it's so awesome that you're going to be great at your bedside ultrasound, because you're going to be able to look at the kidney after the EFAST exam if we teach that and say, hey, I see hydro, I can see the enlarged calyces, I can see this or that, and they can kind of help clue you in, okay? All right, remember, chest pain and neurological complaints, and it could be anything. It's usually stroke-like symptoms 30% of the time. All right, the further distal, as it goes down the aorta, it could be back, flank, even leg pain, kind of groin pain kind of stuff. We're gonna ask questions about risk factors. What did I tell you some risk factors are for any kind of aneurysm or dissection? What are risk factors? Coronary artery disease, old, what else? Hypertension. Methamphetamine use, connective tissue disorders. You guys are awesome. Don't forget about Ehlers-Danlos and all the other connective tissue. Great. We're going to ask about those. We're also going to ask about family history of AAA, right, or dissection, or weird bicuspid aortic valves. Those people are at high risk for dissection. And then sudden cardiac death may not have been from an MI, could have been from a giant dissection. So we need to ask about those questions. Here's some differential diagnoses. We've already talked about this. You guys, some people just like a chart. Who here likes charts? Nobody? There's a couple, okay, so this is for you, I put it in for you, some people like charts for differentials. Anyway, so when you're doing your physical exam, what did I tell you right away? I always do because I'm scared, okay, because I practice, not because I've been sued yet. I suppose if I practice long enough, that's probably not real wood. There's probably no real wood at the Center of Excellence. Anyway, what are the first few things we want to do on physical exam? What do we need to know right away? So we're going to listen to heart and lungs because we're going to listen to specific things. We always do heart and lungs on everybody, but on the heart exam, we might hear something very distinct. What might we hear? You can hear carotid bruit maybe, or you can also hear an abdominal aortic bruit. But on the chest exam, the heart itself, you may hear a new aortic regurg murmur. Now remember, all diastolic murmurs are pathologic. You guys know a little acronym to remember what's systolic or diastolic murmurs? Mr. Arts? Mr. M-R-A-R-T-S? So all those are systolic. Mr. Arts. So mitral regurg, aortic stenosis. Wait, did I say that right? It's Mr. Astor. Did I say Mr. Arts? I'm just here to confuse you, okay? I'm here to just challenge you and myself. It should be Mr. Astor, A-S-T-R. Those are your systolic murmurs. Everything opposite of that are your diastolic, and all diastolic are pathological. So Mr. Astor, which are systolic murmurs, are your mitral regurg, aortic stenosis, and tricuspid regurg. Those are systolic murmurs. Does it matter if it's systolic or diastolic? Yeah, because systolic murmurs are generally not pathological. Anything diastolic are pathological or something bad. So aortic regurg is a diastolic murmur, okay? The opposite of Mr. Astor is Ms. Arts. So you'll need that for your board exam. Just a little pearl for you. It would have gone over a lot easier if I hadn't screwed it up the first time, right? Okay, but I'm human. I'm not infallible. Okay. So we're going to evaluate vital signs because vital signs are vital. We're going to listen to the heart. We're looking for a new aortic regurg murmur. We're going to check radiofemoral delay real quick. Make sure there's no delay. If there's a delay, what's that? That's suggestive of dissection. Now, can some people have some atherosclerotic disease and have a little bit of variation between one limb to another with blood pressure and pulse? Absolutely. But if it's profound, you know, or even if it's not, and you're like, hey, with the right story, this is dissection. Just, there should not be too much of a delay. We're going to listen for that aortic insufficiency, also known as aortic regurg, all right? Pulse deficits are bad. We're going to do a quick neuro exam. We got to know if there's any focal neurological deficits. Look for Horners. Listen for those carotid artery bruits. Listen to the lungs. See if they have a new left-sided pleural effusion. All right, these are all really important. Dysphagia, hoarseness, any stroke-like symptoms, paraplegia, quadriplegia, weakness on one side, just weakness. Straight 3 out of 5 on one side, 5 out of 5 on the other. Just weakness can suggest dissection. Okay. So we're also looking at the ECG. We're doing a quick physical exam and vitals. Do the vital signs really matter right now? Of course they do, they're vital, they always matter. So a lot of these patients will present with hypertension. If they present with hypotension, they're already in cardiogenic shock and they're probably going to die, no matter what you do, okay? It's just so bad. So how do we make this? Well, history, a good physical exam, a quick bedside ECG, ultrasound, portable chest x-ray is gonna help you. And then, you know, sometimes they present with syncope, so it's always on my differential and somebody with syncope, all right? I literally just admitted a little lady the other day that I thought had a dissection for syncope with no prodrome, and we had to do a CT angio. Anyway, they may present with syncope, all right? So ECG, we've got to do this for everybody because we got to rule out that acute coronary syndrome, right? We got to rule that out, and it's scary because sometimes it will affect the inferior heart and it will look like an inferior MI, but you're going to be so smart because they're going to present with some other neurological deficit of some sort. You're going to be like, no, this looks like an inferior MI, but I'm so astute and smart. This patient has an abnormal neurological exam. I think it's dissection. We're going to hold on the nitrates until I can confirm, and that's perfectly normal. Which also brings us to the point where we're going to also hold that aspirin and antiplatelet agents until we know otherwise. So you can see how this is scary, right? Is anybody scared by this? It scares me every single day. Okay. You can find abnormal ECG stuff like new Q waves, maybe some ST segment elevation. It's looking like a STEMI, so every STEMI, make sure you rule out dissection. Most of the time they have the nerve and audacity to present with non-specific ST and T wave changes. That makes me so mad. That's not helpful. I'm like, how dare you, okay? All right, ECG is normal some of the times, and then believe it or not, about 20% of the time, because of diabetes or because once we're elderly, we have decreased sensation to our visceral fibers and stuff. They'll actually not even present with pain. They'll just present with like syncope. No pain anywhere, just syncope, all right? All right, so biomarkers, we talked about this. Some of you said that you would do a D-dimer on this patient because the top three diagnoses we're ruling out is acute coronary syndrome, dissection, and PE. And guess what? Most of the time, a dissection will have a positive D-dimer. So that helps you kind of know that you have to do imaging, which was the case of the woman that I thought had a PE that ended up having a dissection, but luckily for me it was small, okay, and she was normotensive. I didn't have to jump and do heroics, but I just got lucky, right? But a D-dimer is not something we routinely do, like I'm gonna do a D-dimer, make sure this person doesn't have dissection. It's not something we really do like that. We usually associate that with PE, but the truth is the literature supports that there's a positive D-dimer almost always with a dissection. Troponin, can they have an elevated troponin with a dissection? Absolutely. Again, misleading, but if it's affecting the coronary blood flow, if it's dissecting right at the arch before it branches off the coronary arteries, then it can affect the coronary blood flow and present with ischemia, ST segment elevation, positive biomarkers because of the ischemia. So again, we have to have a high index of suspicion. So we're going to do a type and cross match with these patients as well. Chest x-ray, what do you expect to find on that quick portable chest x-ray? You know, I don't wait for the guy or gal who's the x-ray tech, you know, they're wheeling their cart around, they're doing a quick portable. I'm like there at the bedside and I'm looking at the image, you know, outside the glass so I don't start glowing because I'm radiated a lot, but I'm looking at the actual machine and I'm looking in real time at that chest x-ray. I'm not gonna wait till they get all the way back and have to load it up into the impact system. I'm looking at it. And what are we looking for? What have you been taught? Yeah, widened mediastinum, how wide? They say at T4, it should never be more than about 7 to 8 millimeters. It's not an exact science. It's kind of an eyeball science, right? It's eyeball medicine. So some of them won't have any abnormalities. Some will have that classic widened mediastinum, all right? And other things that includes are that new pleural effusion, which almost always happens on the left side. Why is that? Yeah, because of the way the arch comes around to the left side and then the rest of the aorta. So it's usually a unilateral pleural effusion. So if you see that and you have those other symptoms suspicious of dissection, that should actually cue you in. Other things called the calcium sign. You ever heard of that? I'm gonna show you some pictures. It's where you see the outline of the aortic knob, and then you just see some calcifications way outside of that. You're like, what the heck is out there, you know? So I'll show you some pictures so you understand. And then worst case, if it's really bad, they'll have a deviation of their trachea and stuff, almost looking like a severe tamponade situation. What happened here? Okay, rude. Somebody gave me the oval, and then all this stuff is screwed up here. My buttons aren't working, seriously. Okay, we're back. Just a minor glitch, and even though I don't know how to operate a remote control, managed to fix that, okay? I will shout out to myself. Okay, this is a normal chest x-ray. Do you guys all agree it looks normal? Even though it has positive arrow signs, does that look normal? Yeah, and it's showing you what the anatomy is. It's reminding you. So on this right side of the patient's heart, we got, you can kind of see the sulcus sign of the lung here, okay? You can see the trachea come down. And we can actually see a little bit of the ascending aorta on the right heart side, or the right side of the patient. On the left side, we see this little aortic arch. We almost always see that. And it gets a little more prominent as we get older. And then you'll see a little bit of the descending aorta. You can see that it's hyperechoic, but it's a little bit different color white. It's more white than the left border of the heart. Can you appreciate that? That's what normal should look like. And then, of course, the opposite lung, etc. And there's a lot more to look at too, but this would be considered wide. So anything greater than 8 centimeters at T4 is absolutely wide. And most of the impact systems, if you're looking at it on your computer, they have a little ruler or caliper button that you can take, and you can drop your caliper here, and here at T4, and if it's greater than 8 centimeters, that's widened mediastinum, okay, which is bad, okay? You with me? What else do we see on this one? Just real glancing. What's that? Yeah, maybe a little pleural effusion or maybe cardiomegaly, right? Very good. You guys are rocking it. What about this? Does that look normal? So this is that classic calcium sign that I want you to be aware of. So this is the aortic knob, and then the rest of the aorta should come down this way, but what we see is calcification coming out this way outside of that knob. The knob is usually the most lateral portion of the aorta, and then it should kind of come down along the heart border here. Once you see any kind of calcifications out here, that's the calcium sign. That is, of course, bad. Good job. Okay, you guys are on it. Okay. All right. So the imaging modality of choice is a CT of the chest, and I am not going to be tricky-ricky on my exam. I'm just going to say CT of the chest with contrast. I'm not going to split hairs between the aortogram or the CT angiogram PE study because each institution labels those a little bit differently. So whatever hospital you get to, you'll be asked a little bit differently. Colonel Gendron is writing the phase 2 exams right now, and his exam answer is CT angiogram of the chest. And a lot of the students in the phase 2 test was like, I want an aortogram because they learn now it's an aortogram, so it was a big source of contention. So each institution, though, calls it something different. When I work in Uvalde, they actually call it a CT angiogram parentheses aorta or CT angiogram parentheses PE. So it's a little different. So for exam purposes, this is a CT angiogram of the chest. You know there's a difference, right? Because at the iliacs, we want to see the infrarenal, we want to see the iliacs if we're really truly looking at the aorta. All right, but the CT with contrast is the imaging modality of choice. It can tell you where the false and true lumens are, where the dissection is occurring, and that's important for those surgeons to be able to surgically manage the patient, have some pre-game going in, right, to kind of understand stuff. Where the flap is, how big it is, if there's rupture, what kind of end organ damage is done, and it's 100% sensitive and specific for dissection. So you'll see it, okay? That's good. 100% medicine is awesome, right? What's the acceptable risk rate in medicine? 1% or less, okay? So in other words, if something's 100%, it's awesome. You're not gonna miss it, okay? So this is what it looks like. So you see the positive arrow signs. Okay, this is the ascending aorta, and here's a descending aorta on this just slice of a CT scan. This is the right side of the patient, this is the left side, and we're looking at it in the vascular window so we can see the vessels. And anyway, this, there's different what's called Hounsfield units. Okay, you can see that this little gray, this little whiter. So this is the false lumen, which is a little grayer. Has some blood in there that's a little old, maybe clotted, that's why it's darker. Then you have the true lumen with the actual aortic blood in it. And then same, this thing is so big that you can actually see it down here in the descending aorta too. This is the descending true lumen, and this little darker gray outside border is the false lumen. So that thing is so ginormous, it went from ascending all the way down to descending. This person's not going to do well, probably, right? Big surgical management. And if you did a scout view of this patient, you can actually follow the dissection from the aortic, here's the ascending aorta, here's the arch. It starts dissecting here and goes all the way down where that line is, all the way down the entire aorta. Badness. Do you guys want me to point more over here? No, you're okay? All right. All right, I just don't want you to feel left out. Okay, now if you hear terminology like TEE and MRA and MR, basically a magnetic resonance imaging angiogram, you can do those studies. How long does it take for an MRI of any sort to be done? Even with the new technology, 15, 20 to 30 minutes, okay? So we don't have time most of the time if somebody's acutely dissecting to even consider an MRI. So CT chest with IV contrast is the imaging modality of choice. The TEE, you can see by transesophageal echo, basically ultrasound, you can see the dissection. However, the patient has to be stable, and be able to cooperate, and it's transesophageal. They're sticking it in their throat to look at it and stuff. So the patient has to be relatively stable, right? Do you agree? Usually they'll do a TEE, looking for some sort of dissection in an elderly that's already presented with aneurysm of their lower abdomen. Maybe they're like 6 centimeters and they just want to make sure they don't have anything else, but they're asymptomatic. They'll go there and do a TEE. So if you're picking out modalities of choice to diagnose, it's a CT all day. That's the gold standard. These, I'm just going to show you, you can use these, but they're not preferred. These are things that are done in the medicine ward. If you did a bedside TEE, you can still see the false lumen and the true lumen. It's really awesome. You can see the little flap here, here, a little intimal flap, true and false lumens. But again, from my exam and in life in the emergency department, the CT is the modality of choice, and it only takes 15 seconds to get through a CT. It's pretty awesome. So what is our treatment strategy? We know how they presented, we suspected it, we did a bunch of bedside stuff, like an ultrasound looking for tamponade, for pneumothorax, we listened to the carotids, we listened to a new aortic regurg murmur, we looked at their belly to see if they had any kind of dilatation in the belly, we did all of that at the bedside, we looked at their ECG to see if they had a STEMI, we did a portable chest looking for wide mediastinum, all that happened within the first 10 or 15 minutes of patient arrival. Now we have to treat. We suspect it because we saw that wide mediastinum, their blood pressure is stable, they can get to CT, but I want to do something first before I send them to CT, and what is that?
Yeah.
We want to control their rate, right? What was our warm-up case patient's rate?
92.
92. So we want to control the rate to 60. So we can do that first. We're going to do short-acting beta blockers. Esmolol or labetalol are usually the ones we use. All right, I'm not going to make you know dosing, okay? We're just short-acting beta. We're going to get that rate down to as close to 60 as we possibly can. If after that, that patient is still hypertense, now we're going to add nitrates. That's our vasodilators, okay? We're going to control the rate, then vasodilate. All right? I don't know why I went backwards. Here we go. After we've controlled the rate to 60, by giving them esmolol or labetalol or short-acting beta, now we're going to add nitrates. And which nitrate can we use? You can use nitroglycerin, you can use nitroprusside, you can use anything you want, all right? Another thing that we do, if a beta blocker is contraindicated, we will do nicardipine or cardine, and we'll put them on a drip, and it kind of does both. And you're like, well, why don't we just do that all the time? Because it doesn't control the rate as well as a beta blocker. But if there's a contraindication or an allergy to beta blocker, we can't give them a beta blocker. Let me say that again. If they have an allergy to a beta blocker, we're going to have to go to one of these it's really going to be nicardipine almost all the time. All right, cardine is the safest. Book answers will tell you other, like clovidipine and some of these other calcium channel blockers, but the nurses, the easiest ones to mix up are the nicardipine, and that matters because if we can get that on board quicker, it will control the rate and vasodilate at the same time, but mostly it doesn't have as good of rate control as the beta blocker. Does that make sense? Did I explain that well? We have the gold standard, which is beta blocker followed by nitrates, and if we can't do that for some reason, we go to nicardipine, and that will help them. Yes, sir?
So do we withhold the nitro if we do nicardipine?
Do we
Like,
withhold?
do we not give them nitro after the?
Yeah, usually it'd be monotherapy. I know, it's weird, because this actually has both properties, and that's why some people are like, why don't you just always use monotherapy? Again, the mainstay of treatment, the way you're gonna help them stop dissecting is to control that rate first. And this is great for blood pressure control, and it will do some interventions of heart rate, just not as well as a beta blocker. But absolutely great question. If you're doing this, if you're doing nicardipine, you're putting them on a nicardipine drip, we're also not adding the nitrates. We're probably just gonna keep titrating this drip up until the pressure is down to a systolic pressure of 120. That's a great question. Man, you guys ask the best questions. I'm telling you. I'm not just buttering you up. I'm telling you the truth. That's like when people present in the ER and they bring their kids in. If they're a pretty baby, I'll say, God, you make pretty babies. But when they're funny looking kids, we call them FLKs, I don't say a word. I'm just like, oh, come here, baby, you know, it's not cutie or whatever. Some of them are funny looking kids, so I'm just saying, I speak the truth. Okay, so treatment strategy number 1, IV labetalol, we're gonna control the rate. These are some of the doses we give, 10 to 20 over 2 minutes, but we're gonna keep giving them little boluses till we can get that rate down to 60, that's it. Again, if it's contraindicated, we can use calcium channel blocker. Nicardipine is preferred. You can do diltiazem, but nicardipine is preferred, all right? Often inadequate as monotherapy. That's why we want to do the 2-drug strategy. What do you think after we're doing this, what's a definitive repair? Treatment, which is repair, okay? This is why I can't tell jokes. I always tell the punchline before, okay, I have limitations, can't have it all. Okay, anyway, remember dissection with any involvement of the ascending aorta or the arch needs a surgeon, a cardiothoracic surgeon. What if your facility doesn't have a CT surgeon? We're gonna transfer quickly, okay? And what if your patient presented with hypotension right away? They're already in cardiogenic shock. What's that? You're gonna pray for them, try to get them to a surgeon right away, right? That's bad, it's usually a bad outcome. And hopefully though, you can still control the rate a little bit, but we can't afford to drop the pressure. So we might have to start resuscitating them with blood products, okay? Endovascular repair is usually the best, and it's usually for type A, and usually done by a CT surgeon, all right? All right, definitive repair, they can stent. A lot of times they will stent, they'll do endovascular repair and also put a stent in, and that way it allows that false lumen to heal, and it keeps the integrity of the true lumen. And the goals of therapy is to expand and stabilize the true lumen, and then allow the body to passively resorb the false lumen. Excuse me, what are you doing today? What you got going on back there? Yeah, you. Yeah, I'm gonna call you out, you're in my class. We're almost done and we're almost at breaks. They needed a little distraction. Okay. Are you getting equipment? Are you doing inventory? What are you doing? Yeah. Okay, lucky you. Okay. All right. What are we gonna do with these folks? If we think they have a true dissection, we're gonna admit them, and they're probably gonna go to the ICU, right? They're probably gonna go to a med-surg ICU. Okay. What if we diagnose somebody with a new abdominal aneurysm and it's greater than 3 centimeters? Maybe they develop abdominal pain that's 5 centimeters. What are we going to do with those people? We're also going to call surgery, admit them. They're probably going to medically manage them, but we're still going to admit. We're not going to let any of these people go home, right? The criteria for admission for an abdominal aneurysm, if you just happen to be playing around, let's say it's just, you're like, hey, I want to get some ultrasounds in to maintain or to request credentials for ultrasound. We did that. I had to do 50 abdominal aortas, 50 hearts, 50 EFAS in order to get credentialed at ultrasound on point of care ultrasound. 50 eyes, 50 DVTs, all that stuff. So anyway, as you're in there playing with a patient that came there with a leg pain, and you're like, hey, can I just look at your aorta? And you happen to look at it and it's greater than 3 centimeters, you're not going to make a big muck of it, okay? But if that patient presented with abdominal pain and they have an abdominal aorta greater than 3 centimeters, it warrants admission and consultation. If incidentally, while you're playing with the ultrasound machine, you happen to find an abdominal aneurysm bigger than 5 centimeters, even though they're asymptomatic, you're also going to admit and consult on those people. Okay, does that make sense? That's too big to be comfortable. So the easy disposition for dissection is you're going to admit everybody. You're going to call surgery. You're going to admit everybody. It's going to be great, and they're going to take special care of them and save their lives. What happens if it's a pregnant lady? Remember I said 3rd trimester of pregnancy is a risk factor for dissection in a woman that didn't have an underlying connective tissue disorder. Just pregnancy alone puts so much stress on the body. We have to call obstetrics and CT surgery, all right, at the same time. It actually increases, and then now if they have like an underlying connective tissue disorder, this pregnant lady, they're even at higher risk for aneurysm and dissection, so that's bad. So some of the complications that can happen, we talked about this already. They can dissect right into the pericardium and present with syncope or hypertension or cardiogenic shock from an immediate cardiac tamponade. That's bad, and we can quickly diagnose that at the bedside ultrasound. So that's one. An aortic regurg murmur can cause cardiogenic shock. It's a diastolic murmur. They can have an aortic free rupture, and then of course end organ ischemia. Anything downrange from the dissection is becoming ischemic. Their brain, their carotids, their their coronary arteries, wherever they're dissecting, everything else is ischemic. That's why they present with neurological symptoms. We're almost done. Whew. That feels like a lot of information. All right, we're almost done. Now this is just a recap. Hypertensive emergency and urgency. What's the difference between the two of those? End organ damage is emergency. Urgency is that it's really high. I might have to do something to make them a little lower, but it's not necessarily, if they don't have any end organ damage, then it's not a huge deal. It's just an inconvenience. How do we know if somebody has end organ damage? Unfortunately, we're gonna have to work them up. We're gonna have to do the troponin. We're gonna have to check their urine, make sure that they don't have hematuria. We're gonna have to make sure everything looks okay, that we ruled out acute coronary syndrome, and that they're not having neurological deficits. We have to prove that they don't have end organ damage. So unfortunately, they both need worked up, and they both need some sort of antihypertensives. These are just some take-home points. People classify hypertensive urgency and emergency based on the systolic pressure mostly. We don't usually just go for diastolic pressure, it's usually systolic. Doesn't mean that diastolic pressure doesn't matter. I'm just saying that usually our end goals are systolic. So if it's greater than 180, most of the time we'll intervene and give them something to lower it, and that's where that 20% rule comes in. We try to lower it by 20%, no more than that. So we go low and slow. And then we just make sure that we do a workup to prove that they don't have end organ damage. But if they're presenting with hypertensive emergency and they're also having acute coronary syndrome, they need to be admitted because they already have proven that they have end organ damage with their acute coronary syndrome. Does that make sense? Any of these body parts can be affected: brain, lungs, kidney, heart. Take-home points. Usually we have to lower the blood pressure in hypertensive emergencies by 20, no more than 30%. 30% is your absolute cutoff. Why do we have a cutoff of lowering blood pressure if it's super high? What if they come in with 230 systolic pressure? I can only reduce that by 30%. Is that true? Yes, it can cause a rebound ischemia. They probably walk around with hypertension every day, and so the brain is used to those pressures, so we have to go low and slow. If they come in with tearing, ripping chest pain radiating to their back with a neurological deficit, then that all bets are off. You need to lower it to a goal of 120. Just to reiterate that, and we're going to start with which kind of agent first? Beta blocker, followed by only if they still have hypertension, we'll add the nitrates, or in the absence of the ability to give them beta blockers because of allergy or intolerance or whatever, we're going to use nicardipine. Very good. A hypertensive urgency, which is non-emergency, just means they have high blood pressure, usually over 180. Some standards say 200 systolic is considered high, and you'll have to maybe intervene. We don't want to reduce the pressure much. I've actually been a victim of this in my practice where I tried to help somebody and it blew up in my face. I'll tell you that terrible story in just a moment, and then we'll go for a break. Yeah, that's we usually don't use these two together, so thank you for pointing that out. That should have said in patients that can't tolerate beta blockers, then you can control with nicardipine. So it's either esmolol nitrates or nicardipine as monotherapy. All right, thank you for pointing that out. I looked at these slides probably 5,000 times, so thank you. Okay, you guys want to hear a quick story before you go to break? I'll give you a break and the next lecture is a little quicker. Okay, dumb story. I was out in Brady, Texas, a lot of country bumpkins out there, and there's this old rancher. They actually show up there to go shoot exotic animals and stuff. And this old rancher guy who runs one of these ranches that have I don't even know what kind of animals, gazelles, sometimes lions, sometimes terrible. Anyway, regardless. So he runs this ranch, and he's an old country bumpkin, hasn't seen a doctor in probably 20 years. He was in his 70s. He came in with a pressure of 240 over 110, and he said he had a headache. And I said, sir, I need to do a CT of your head. I need to get IV access. I need to make sure your heart's okay. I need to do this workup. He said, no, I'm not getting any of that. Just give me something, get rid of my headache, and let me get out of here. And I was like, well, sir, I really need to do X, Y, and Z. Your blood pressure's just off the charts. It's just too high for me to feel comfortable. I'd like to lower it a little bit. And he's like, nope, I'm not doing it. I refuse all treatment. And I said, well, sir, if you leave, you could die. And he's like, well, just give me something for my headache. And if you're worried about my blood pressure, give me one thing to just kind of lower it a little bit. Well, here's somebody who's never been on blood pressure medicine. And I'm like, you know, what am I going to do? So I'm out there by myself. I'm like, okay, I'll just give him something kind of benign. I'll give him 0.1 milligrams of oral Klonopin, okay? Just not a beta blocker, not a calcium, just something kind of, and that's what they use sometimes as a, like people who are chronically on beta blockers, they'll have some Klonopin at home, and their own doctor will say, if your pressure ever gets above 200, take this, wait 20 or 30 minutes, if it's still high, go to the ER. So it's kind of like a backup. Anyway, so I was like, okay, we'll just lower it, it won't lower it that much, it'll be fine. So I gave him 0.1 of Klonopin, watched him for a little while, his pressure came down to about 180, 185. Headache got better, gave him a little Tylenol for his headache, he felt great, no pulse deficits or anything. He finally let us do an ECG, ECG looked good, that's all he let us do. No imaging, nothing else, and he's like, I'm ready to go, I'm leaving. And of course, I was like, guys, leaving AMA, because I asked to do this workup. But anyway, I still educated him. He leaves, I'm on a 24-hour shift. About 5 hours go by, I get wheeled in an ambulance for somebody who lost consciousness and ran off the road and hit a tree, and it was him. His pressure continued to drop, even with 0.1 of Klonopin, the lowest dose of medicine possible, to the point where he lost consciousness and he hit a tree. Luckily, he was okay, but he came in ranting and raving, blaming me for his low blood pressure, and you know, some days you just can't win, okay? And luckily, I had thoroughly, you know, documented, hey, guy refused everything, refused workup, he left AMA, whatever, so he was fine, and it's not like he was going fast, his car wasn't even that damaged, but, you know, I'm just like, you know, you can't win for losing. So it drives home the point that if they're not having a hypertensive emergency, you know, as much as we want to do something to try to acutely control blood pressure in the emergency department is actually dangerous, okay? So anyway, let's take a break. I know I went over just a few minutes, and I know you guys are very protective. Appreciate you guys telling me when there's a mistake on the slide. Just to sum up any confusion, we want in a dissection patient, if we can, we prefer the dual treatment with a beta blocker and a nitrate. And the reason why is the beta blocker is going to control the rate the best, the nitrate's going to vasodilate the best. If you can't use those two drugs for whatever reason, maybe an allergy or a contraindication, then you can do nicardipine is great. It does have some rate control, and it's got good vasodilator properties, okay? And so the preferred is the dual drug therapy. You can also use nicardipine. I corrected my slides, so I appreciate you, because it helps me, and I do it right away when somebody gives me feedback, so I don't already forget by the time I go home, because it's just really hard being me, and I probably forget when I get home, so thank you, I appreciate that. I just want to make sure there's no confusion. If I give you a vignette, your preferred treatment, it's obvious dissection, it's going to be a beta blocker and a nitrate. If I give you a contraindication to a beta blocker for some reason, you're going to go to nicardipine, okay? And there's other calcium channel blockers that you can use, but in real life, nicardipine is easiest for the nurses to mix up and drip in, and you can titrate it up or down really easily, so that's why we prefer it. Make sense? All right, word. All right, let's moving on. Who's excited about heart failure? What? That's what I thought, me too. Okay, so why I had your attention for the first few minutes, I kind of led on to this the other day. We can put heart failure into 3 buckets, all right, and it's all based on blood pressure. So if you pay attention, the vignette will be something like somebody presents with, what are symptoms of heart failure? Dyspnea, shortness of breath, dyspnea on exertion, orthopnea, PND, pedal edema, okay, maybe chest pain, all right? All of those are symptoms of heart failure. They present with that, and then you can look at their vital signs. If they're hypertensive with heart failure, we're going to address the blood pressure first, usually with nitrates. If they're normotensive, their systolic pressure is normal, and there's signs of fluid overload, we're going to diurese them. And if they're hypotense, they're in cardiogenic shock, we're going to treat them with what? Pressors. You guys kind of learn this warm, dry, cold, wet thing, and that's fine if that works for you. That doesn't work for me because I've seen CHF people that need, you know, that are septic, that need fluids, you know, so, and they're hot and dry, or they can be cool and wet. There's all kinds of differentiations that I've seen. So however you remember it is fine. I'm not trying to contradict that, but I want you to pay attention to the vital signs. Look at the systolic pressure. Of course, diastolic too, or the pulse pressure, but look at the whole thing. Look at their vital signs when they make a determination, all right? I'm just gonna plant that seed right away. It makes it easier to treat acute heart failure in the ER. And sometimes when they have acute heart failure with flash pulmonary edema, you can put them on BiPAP, and as soon as you give them nitrates, they can breathe. It's amazing. So I just want you to be able to act quick and think about these 3 little buckets. It makes things a little more simplified so you can react quickly. Make sense? Okay, so here's Titinelli. Here's the things we're going to talk about as usual. I like to give you some pathophys, how they present, how we work them up, how we treat them, what we do with them. All right, let's do a warm-up case. I'll read this one to you because it's a long vignette, kind of like your test questions. A 53-year-old man presents with complaints of shortness of breath and headache. He has a history of diabetes and hypertension, but hasn't taken his medications lately because he can't afford them. Can you guys see okay with that door open? Do you want it open? Okay, I know it's hot. I know. Okay. He was okay until about 4 days ago. He developed mild exertional shortness of breath, dyspnea on exertion, and it's worsened since then. He's had a 2 to 3 orthopnea. 2 to 3 pillow orthopnea last night and developed a band-like headache this morning. He's complained of substernal chest pressure, unlike his previous angina, so not like his prior heart attack. It started last night. He rates it as a 4 out of 10. It does not radiate. He does not have nausea or vomiting. That's his blood pressure, heart rate, saturations, and temperature. Right away, because he's having chest pain, what's our differential? ACS, PE, dissection, okay? And then there's those other 3 that we can roll out at the bedside. Tamponade, Boerhaave, and tension pneumothorax. Very good. Okay, so what are our treatment priorities in this patient? Does this sound like a dissection patient? Could it be? Sure. So what are we going to do real quick at the bedside? What's this patient going to get right away within the first few minutes? This ECG, a physical exam by you, listening to their heart and lungs. You're going to check their radio pulses real quick to make sure that there's no radiofemoral delay, radial delay. Okay, what else? Portable chest x-ray, looking for cardiomegaly or widened mediastinum. Okay, perfect. And what are our treatment priorities? Now, what's his systolic pressure doing? It's off the charts. When I told you to put it in 3 buckets, if they're presenting like heart failure, we just did the bedside ultrasound real quick too to make sure there's no cardiac tamponade, tension pneumothorax. Okay, he hasn't been vomiting. I just said he has no nausea vomiting, so it's not Boerhaave. So now, how am I going to treat this patient? If they're hypertensive in heart failure, what am I going to do? Address the blood pressure. I address it with what? Nitrates, right? Nitrates. Perfect, all right? And it happens to be the same treatment we give for ACS. So we're kind of safe here. So again, approach to the critical patient, we're going to stabilize their ABCs, make sure they have a patent airway. If they're having dyspnea from their acute flash pulmonary edema, from their profound elevation of blood pressure and heart failure, we're going to start BiPAP right away. We're going to start it. We're going to do it at the same time we're doing the nitrates, addressing the blood pressure. So there's something called sympathetic acute crashing pulmonary edema, SCAPE. Have you ever heard of that? Okay, that's what they present. They're bent over, they can't breathe, they're clutching their chest, they look like they're gonna die. Their pressure's off the charts, 220 systolic. You do your quick little bedside things that I just said, including a neuro exam, heart exam, radial, all that stuff, making sure it doesn't radiate to the back, it wasn't tearing, ripping in nature. Look at their ECG, look at their chest x-ray, quick bedside ultrasound. At that point, if they don't have any of those things, at the same time you're ordering BiPAP at the bedside to help them, especially if they're having dyspnea or hypoxemia, and now we're gonna order nitrates. And you can do all kinds of nitrates. You can give them a sublingual nitro. That's 400 micrograms of nitroglycerin. That's a lot. That's the same cardiac dose for people out of the angina. Just give them a 400 microgram under the tongue dissolvable tablet. That will reduce their pressure. All right, you don't even have to have IV access yet. You should, but you may not have it. Anyway, we might provide BiPAP. IV nitrates is better because it reduces preload and afterload, especially at high doses. And that's what we want. We want to decrease that pressure because once you do, guess what? Their heart failure exacerbation goes away. If there's still signs of volume overload after you reduce their pressure to normal, now you can diurese them. but it won't do them any good if you diurese them first. You gotta control that pressure. Otherwise, they'll keep circling the drain and having a difficult time breathing. Are you with me? Are you sure? It's almost lunch, you're looking a little tired. I wish I could postpone this one for another day. I smell food, it's making me hungry. Okay, all right. Consider loop diuretics if the patient has fluid overload after you've done this other stuff, if they have heart failure and high blood pressure. All right? All right, what if they have acute heart failure and low blood pressure? They're in cardiogenic shock. What do? Support their airway and breathing, make sure they have a patent airway. Maybe provide some oxygen if they need it, right? And maybe BiPAP, but if they're already low blood pressure, you start somebody on BiPAP, it can lower their pressure more. That positive pressure ventilation, where we're used to negative inspiration, a negative pressure system, can actually reduce their blood pressure more. So make sure you have IV access. 2 is 1, 1 is none. That way, if the patient's blood pressure drops even more, you can get pressors on board, which you should be getting ready already because they're already presenting in shock. And then we're going to correct whatever the underlying reason is for shock. Usually it's cardiogenic shock. So we're going to start like a dobutamine or something. And maybe some small fluid challenges like 250 cc's of fluids, 500 cc's. We don't want to give them too much because we don't want to fluid overload our heart failure patient. Maybe give them little aliquots and support their blood pressure. And then consider dobutamine. Usually it's dobutamine, or you can do norepi or epi. You with me? Okay, that summarizes it. So heart failure is a big deal. It's when the heart can't meet the metabolic demands of the body. A lot of disease processes can cause it. Most of the time when they come in with a heart failure, like a COPD person, when they present, most of the time we admit them. When a heart failure patient comes in with acute exacerbation, we almost always admit them. Okay, it really took them forever just to come in for their heart failure exacerbation, so almost always the disposition is admission. If you are diagnosed with heart failure, you have a poor prognosis. Half of the people die within 5 years, so it's a bad thing to have. And I've seen patients develop heart failure, post-viral, things like that. These cardinal symptoms that you already know, the shortness of breath, dyspnea on exertion, fluid, like pedal edema. Where else can you have fluid? In your lungs? Where else? In your abdomen, it can be everywhere, right? Sometimes we induce a heart failure in somebody who has underlying disease. We're like, oh, you came in for your back pain. Here's a bunch of NSAIDs. NSAIDs can precipitate heart failure, so can beta blockers. All right, we just put patients on beta blockers for their hypertension. It might make them go into heart failure. It might be people who can't tolerate it. So get a good medication history when you're talking to these people. We know that they secrete BNP. We talked about this before. BNP is secreted from where? Okay, from the heart, good, not the brain. And it can be elevated. It can also be falsely elevated in other conditions like COPD and PE. However, if it's off the charts elevation, it's almost specific to heart failure, okay? All right, so when we classify heart failure, I'm only gonna make you remember HFrEF, HFpEF, okay? All right, is that what you guys learned in cardio? Back in the day, they used to say, well, what part of the heart is affected? Is it systolic or diastolic? It doesn't matter. It's either HFpEF or HFrEF, and everything in between is mid-range, called HFmEF. Have you heard of HFmEF? That's just mid-range. And most of the time, we treat it like HFrEF, okay? So that's what you need. But I'm going to flip over these slides really quickly because I'm just letting you know that these other terms are kind of obsolete now. And it used to be, some people go by symptoms, and that's still the New York Heart Classification. That's great. When you're in an outpatient scenario in family medicine, you can say, oh, I think you're class 4 because you have symptoms at rest. That's great. That does nothing for acute exacerbation in the emergency department. Again, we're looking at HFrEF or HFpEF. All right? Also, they talk about which side of the heart, systolic, diastolic. I took all those slides out because it doesn't really matter. What you need to know is, do they have preserved or reduced ejection fraction? What is reduced ejection fraction? How much? To 40% or less. Do you know at BAMC, if I call cardiology, the cardiology care unit, they have a CCU, which is a special ICU for just cardiac patients. If I call them and say, hey, Ms. Smith is having an acute heart failure exacerbation and she has HFrEF, they'll say, well, what was her last echo? What was her ejection fraction? I was like, oh, her last echo showed an ejection fraction of 36%. They're like, okay, she's not sick enough. We only take if it's less than 30%. I'm like, Okay, so I called medicine and say, hey, admit this patient. So each hospital has their own little weird criteria, but it's either reduced or preserved, and that's what we care about. And again, preserved is anything greater than 50. What's normal? 60, 65, right? 65. So it's still a little reduced, but that's preserved enough to maintain function and meet the metabolic demands of the body. Okay, so usually these people are presenting with acute on chronic heart failure. So it doesn't just happen all of a sudden. They're not just walking and all of a sudden chest pain, shortness of breath. This is like, hey, I've had a 5-pound weight gain over the last day or two, or maybe a 15-pound weight gain over the last week. My feet have been swelling up more, and notice my shoes are tighter. It's usually a slow onset, like a COPD patient. It kind of comes on over several days and weeks. Do you agree with me? Is that how you were taught previously? Okay, good. Okay, and it can be, left versus right. I'm not going to make you split those hairs because it doesn't matter acutely. In the emergency department, I want you to pay attention to their systolic pressure and maintain it, and then diurese them. What kind of historical things might you ask your patient that might be helpful in working your CH application up? I'm sorry? Yeah, I mean, if somebody says, I've had a long history of heart failure, and now I'm having fluid retention, then they're probably having a heart failure exacerbation, all right? But if they've never had it before, like if they're the ages 20 to 50 and it's new onset, they could have a dilated cardiomyopathy, so keep that in your mind. But here's some risk factors, and we talk about hypertension, diabetes, maybe they have valvular heart disease, things like that. They're old, male, obese, they smoke. And dyspnea on exertion is the highest, most prevalent symptom that they'll present with, dyspnea on exertion. And other more specific symptoms are like PND, orthopnea, pedal edema. Those are all the buzzwords for heart failure. Do you agree? You associate any of those with heart failure? Okay, good. Other symptoms, maybe dyspnea at rest, exercise intolerance, dependent edema. Maybe they just say they're weak or fatigued. That's all kind of the same thing, but some people just describe it a little bit differently. But we're looking at dyspnea on exertion, PND, orthopnea, pedal edema. Those 4 top symptoms. Okay, on physical exam, what do you think they're going to look like? They're having acute on chronic heart failure. What's that? Yeah, I mean, when you can't breathe, has anybody ever been in a situation where you can't breathe? I had a high epidural one time, and they paralyzed my vocal cords in the recovery room, and I couldn't even phonate. And I'll tell you what, I was like freaking out, right? And I was trying to write down, like, turn off my epidural drip, but I was tripoding, couldn't breathe, and I had some nurse come and say, I need you to calm down. And I was like, I swear to God, if I see her outside, if I live through this and I see her outside, I'm gonna punch her in the face. Even though I've never punched anybody in the face before, and I still didn't do that, okay? Because I'm a very forgiving person. But if you've ever been in respiratory distress, it's pretty anxiety provoking. So they could look anxious, all right? What if they have underlying COPD or emphysema? What might they look like? They're like a pink puffer, right? Remember I told you they're like crack hose, but they don't do crack? Okay, I put that in there, I'm sorry. It's true, that's what they look like. They can be pale looking, diaphoretic. They can have peripheral cyanosis, kind of blue looking, right? Because they're just not perfusing well. On their chest exam, they're tachypneic. They can have a cough, right? They can have like pink tinged sputum. Have you heard that during your cardiology? They have this pink frothy sputum from their heart failure. When you listen to them, you're going to hear rows, wheezing, maybe pleural effusions, frothy blood tinged sputum, like I just said, maybe murmurs, tachycardia, could be a number of things. All right? Abdomen, GU, they can have hepatomegaly. You guys do all that little reflex stuff. They could have right upper quadrant tenderness because of their hepatomegaly. They could have ascites, a bunch of fluid. Remember I told you that some of the elderly men that I've seen with really bad heart failure exacerbations, their scrotums get ginormous, like they can't walk. So it can be anywhere in the abdomen and GU area as well as their legs, okay? I've seen them where the entire leg is swollen, including their abdomen, all right? On their skin, what is this? What is this person doing? It's pitting edema. I've seen it so bad that it's liquid weeping through the skin and it's wet. It's like a serious yellow just weeping through the skin. Has anybody seen that? It's so awful, but that's really severe edema. Anasarca, cool, clammy extremities sometimes, okay, especially if they're hypotense, but not always. On chest x-ray, what do we expect to see on somebody with heart failure? I'm going through this quickly because you've already had this. You guys know this stuff, and you seem to have a good grasp. Chest x-ray, what do we see? Cardiomegaly, what else? Pulmonary edema. Remember we said at the respiratory lecture, I talked to you about the ultrasound B lines. Okay, we can do a quick bedside ultrasound looking for that pneumothorax with your little probe, and you're going to see B lines. Okay, instead of looking like ants moving, which you should still see because they don't have a pneumothorax, is you're going to look like somebody that had a giant flashlight in the forest at night, or like a whatever those things are in Star Wars, lightsabers. It's going to be going all the way down. You're going to see more than 3 in one little lung window. That's a B line. You're going to see a bunch of that. Okay, maybe pulmonary edema. This is what it looks like on chest x-ray. You get a big, wide heart, like cardiomegaly, and you see all these little interstitial alveolar effusions. That's pulmonary edema. All right, that's bad. That means that there's fluid. All these people with chest pain, guess what they get? They get an ECG. An ECG may not show STEMI or ischemia, but a lot of times they'll have LVH or left atrial enlargement. You'll see a lot of voltage. There are going to be some abnormalities associated with heart failure exacerbation. It doesn't have to always go to the point of ischemia or STEMI, but they're going to have some abnormalities that are non-specific. Bedside point of care ultrasound, boom, you're going to learn how to do this. This is awesome. We're going to do 3 things. We want to know, are there signs of pulmonary congestion? Are there signs of volume overload? And what is that ejection fraction? Is this a half-PEF or half-REF situation? Let's say there's not an echo in the system, and you're going to do that eyeball technique, okay? Anybody want to learn something you can do at the bedside real quick? So do I. It's good stuff. All right, show me the POCUS. Again, the first question of 3, we're going to ask, is there pulmonary congestion? That's looking for those B lines. Are there signs of volume overload? We can just do a bedside ultrasound and be sure. They look dry, I don't know, are they wet? You can actually make a bedside determination by looking at their inferior vena cava. That's the second question we're going to ask. And the third question is, how is that ejection fraction looking? Does it look like it's preserved or reduced? I'm going to show you how to do that. So when we're looking at the B lines, we're going to look at that one lung window, and we're looking for 3 or more of those flashing things called B lines. And if there's 3 or more in one window, that's what it looks like. Don't you agree? It looks like somebody in a dark forest with a flashlight, lots of fog around. It's kind of ominous. If you see more than 3, this is one lung window because we have a rib shadow here, ribs up here blocking the ultrasound beam. We have a rib. We have another rib here on this side, and then in between is this pleural line. If we see 3 or more of those long lines in one window, that means there's pulmonary congestion or fluid, okay? And this is what a video of it looks like, okay? You see a bunch of those coming down? How many did you see? Yeah, one window, we're moving around. This is one window here, so there's more than 3. Do you agree? I mean, if somebody could have a steady hand, it sure would be helpful for my videos. Okay, so here's another more obvious one. This is still one lung window. You guys see all those? Do you agree there's more than 3? There's like 8 or 9, right? That person's got a lot of fluid. So my first question is answered. Is there pulmonary congestion, yes or no? If that's the ultrasound, do you guys agree? Yes, there's pulmonary congestion? I agree too. Okay, now let's look at our second question. Now what we can do, the IVC, the inferior vena cava, is right next to the aorta in the abdomen. We're going to place our probe on it, and we're going to look. And a normal person, the inferior vena cava is about 2 centimeters, which is different. The aorta is 3 centimeters. And the way we can tell if we're on the IVC versus the aorta is that the IVC, when somebody sniffs, it'll collapse 50% or so. It collapses, okay? It's a vessel, right? Negative pressure. Or if they valsalva, it's going to shoot out and get really big and fat. Okay, and you guys like to do that when we're doing the EFAST, which is pretty cool, and I'll show it to you. But anyway, this is what the IVC looks like. And this person right here, we're just doing it, and right there they sniffed. See when right there they're sniffing, they're going, and it's collapsing. So it should be 2 centimeters, and it should only collapse about 50% and then come back to normal in between their sniffing. Okay, that means they're normal volume status. If when they're sniffing, it's wall-to-wall completely collapsed, they're volume down. If it's completely fat and it doesn't move at all when they inhale or like sniff, they're in volume overload. So that helps you because at the bedside you can tell right away if it's plethoric, which is another word of super fat, you know that you need to diurese those patients. But if they're down and it's collapsing, those people need a little bit of fluid, even though they have heart failure and heart failure exacerbation because of their underlying sepsis or whatever, they're dry. And that's important, so we diurese the right people and not kill the kidneys on the people that didn't need it. Does that make sense? All right, so here's another one. What do you think about this one? This person's sniffing right here. What do you think? Skinny, normal, or fat? Fat. This person needs to be diuresed. And this is awesome. You can do this right at the bedside. What do you think about this one? Person sniffing? Right there. Did it collapse more than half? Yeah, this person's volume down. This person needs fluids. And when we give fluids to heart failure patients, we do a little tiny aliquots, 250 cc's at a time to kind of reassess because we don't want to overload them. Does that make sense? Anybody need me to run through these again? If it's super fat and they're presenting with heart failure, they need to be diuresed at some point. We're still going to go by their blood pressure as to when we institute that diuresis, okay? But if it's fat, they need diuretics. If they're volume down, they need a little bit of fluid. And if they're normal, they probably don't need either. Okay, you with me? All right. Now the last of the three questions at our bedside ultrasound when we're managing a heart failure is we want to know what the ejection fraction is. If they said, I just had an echo yesterday, my results should be in the computer, that would be awesome, okay? That almost never happens, okay? So what we're looking at is the same view. This is the parasternal lung. This is the same view that we use for one of our alternate views for our EFAST. Probe markers towards the patient's left hip. We're just around the third or fourth intercostal space, kind of angled like so, and we're looking at the heart. And by doing that, we see the right ventricle at the top, as you can see here. We can't see the right atria, but we don't care about the right atria right now. We can see the right ventricle, and what we're really paying attention to is this big left ventricle, okay? This right here is the left atria. So if this is the left atria, and this whole thing here is the left ventricle, which valve is this? Mitral valve. You did much better than the last time I asked that same question, okay? All right, I'm just saying, doing good. All right, so this is the left ventricular outflow tract. It's going to go out the ventricle when it squeezes and out through the aorta. So what valve is this? Aortic valve, right? So as you can see, with each beat, these little leaflets are slapping the septum. Do you guys agree? It's slapping the wall. This is slapping the septum. Everything looks hyperdynamic. That's what a normal ejection fraction is. I can't tell you what the percentage is. I can just say that's normal, okay? And that's all you have to do on a bedside. Is this a normal EF? Okay, are you with me? Is this blowing your mind? Yes. It is? It's gonna be okay. You're gonna get more ultrasound. I'm not gonna be tricky, all right? Just eyeball this and tell me what you think. If I said this is normal, now look at this heart. What do you think? Looks a little wimpy. See, you are empowered. You do know this. This is AB normal. That's all you need to know. This is normal. This is AB normal. Okay, not normal. That's wimpy. It doesn't look like it's squeezing hard. Do you really think that this is meeting the metabolic demands of the body? Probably not. Okay. Now, when we work these folks up, we might have to do a few labs. What are some labs we're going to do? Well, we don't know if it's a PE. We don't know if it's dissection. We don't know if it's acute coronary syndrome. We're still ruling out those other things, so we're going to do those same labs. The CBC to check for anemia, infection. BMP, okay, we need to know how the kidneys are functioning before we put them on medications and diurese them, right? Liver enzymes, why are those important? Why? So they could have congestion just from liver dysfunction, right? They could have some sort of liver disease or autoimmune hepatitis. Plus, liver enzymes are acute phase reactants, so they can react to infections, so that's important. What about a BNP? Well, this is the mainstay lab of CHF. Do you agree? If we know their baseline BNP is 3,000 and today it's 18,000, it's highly suggestive that they're having a heart failure exacerbation. Do you agree? It's really nice to know that baseline number. I've lost some of you. Where have you gone? Where are you at? Where are you thinking of your vacation after this semester? Yeah, I don't blame you. Okay. All right, troponin, why is that important? Yeah, we got to rule out ACS, right? Or they could have a secondary instami because of the strain of their body because of heart failure. So they could still have acute coronary syndrome with heart failure exacerbation. TSH, why would we need a thyroid stimulating hormone test? That's right, they can have thyrotoxicosis causing heart failure, very good. Urinalysis, maybe it's an underlying infection causing heart failure exacerbation. Usually something throws them into heart failure exacerbation, whether it be an infection, non-compliance of their medications, maybe a heart attack, maybe a pneumonia. We're looking for stuff. Venous blood gas, especially if they're having any kind of signs of difficulty breathing because of their heart failure. Magnesium and phosphorus labs, why are those important? Yeah, because electrolyte abnormalities are bad in patients with underlying cardiac disease. It predisposes them to even more arrhythmias, and more arrhythmias will worsen heart failure. They're all connected, it's important. Okay, good. BNP is great. I always add that on anybody that comes in with chest pain who is either elderly or if they present with shortness of breath. I always add a BNP on the labs, always. And it helps, especially if you can know their baseline. There's different types of BNP out there. There's regular BNP and there's something called a pro BNP. Just know regular BNP, if it's greater than 500, it's absolutely some element of heart failure. And on a pro BNP, if it's greater than 900, there's some degree of heart failure. Normal is less than 100 of regular BNP or less than 300 of pro BNP. So if I did a pro BNP on all of you, you should all be less than 300. And pro BNP is the newer one that most people are using now, okay? Everybody in this classroom should be under 300 unless you have heart failure, which you don't. Okay, so remember, approach to the critical patient, we're gonna IV O2 monitor, secure their airway if they need it, give them oxygenation and to support their breathing. And if they're really having a difficult time, like those super hypertense patients that are coming in with flash pulmonary edema, we're gonna start them on BiPAP right away. And usually we start it on like 10/5 or 12/6, something like that. And then we're gonna get circulation and support them. That means IV access, 2 is 1, 1 is none. If they need pressors, we're gonna start that. If they're dry, because our bedside ultrasound showed me that they were dry, we may give them a little tiny bolus of fluid of like 250 cc's. And you're like, wait a second, they're having heart failure. Why would I do that? Because not everybody needs diuretics, all right? Not everybody needs it. We're gonna monitor them by end-tidal CO2, and if they absolutely start losing their airway and losing consciousness and they can't participate with BiPAP, what am I gonna have to do? What are you gonna have to do? Intubate them to secure their airway. Very good. They have to, in order to tolerate BiPAP, they have to be alert, oriented, and work with the BiPAP machine. There's other things that we can give them to support their oxygenation. We can do nasal cannula, non-rebreather. There's something called a high flow nasal insufflation. That's a little different. It's a special nasal cannula that they can do high volumes, more than just the 6 liters per minute basic nasal cannula. There's all kinds of adjuncts we can do at the bedside to support their breathing. All right, let's go through it one more time, then we're almost done. We're gonna be break. High blood pressure and heart failure, okay? Usually that's because they have pulmonary edema and hypoxia. We're gonna lower their blood pressure. We're gonna look at that blood pressure, we're gonna lower it. What goal should we do for acute heart failure? Yeah, just the 20% or so. We don't, if we don't think it's dissection, we ruled it out by our little bedside, and just reduce it by 20% and give them some respiratory support, they'll turn around. They'll turn around really quickly. I've seen patients come in, they look like they're about to die. We give them 1 dose of nitro, a little bit of BiPAP, and literally 5 minutes later, they're like, I feel great, can I go home? Like, it's that quick, all right? Only if they're short of breath, you might consider oxygen therapy and BiPAP. And if after you've reduced the blood pressure and they're definitely wet and they have signs of volume overload, now we can diurese them. You get them fairly reduced first with their blood pressure, then diuretics, okay? You can start with nitro. You can do nitroprusside, nitroglycerin. You can give them 400 micrograms of sublingual. What most of us will do is just start them on a nitro drip and then titrate to effect. Once their pressure starts getting too low, we'll turn it down or off, okay? Complication is hypotension. If somebody's on a nitro drip and their blood pressure drops, what am I gonna do? Stop the drip. And guess what? Their blood pressure comes right back up because nitro is short acting, okay? Rapidly lowering the pressure too much can actually lead to intubation, okay? So we don't want that. So just kind of watch it. Nitroprusside is also a great agent, but in a lot of books, the nitroprusside is the right book answer, but most nurses don't know how to titrate this or mix it up. It's very hard, and there's mistakes, and it's just hard. Even though it's a book answer, we almost never use it because it's hard to mix. So nitroglycerin is easy, just very easy. So we usually use that first. Okay, oxygen if they have dyspnea, loop diuretics like furosemide, Lasix if they are in fluid overload. And we usually try to give about twice the dose of their home dose. This is what confuses some people, okay? So what's twice their home dose? Let's say they've never had Lasix and they're in fluid overload with heart failure, we'll just give them 40 IV. But if they're on 80 orally at home, 40 IV is the equal to 80 orally, because IV form is twice as strong. So if somebody's on 80 orally daily, I want to give them twice their daily dose, how much IV Lasix am I going to give the person that takes 80 orally in order for them to get twice as much? 80 IV, which is equivalent to 160. So I just want you to know that when you give them 40 IV, it's equivalent to 80 orally. And when you give them 80 IV, it's equivalent to 160. And that's perfect because we want to give them twice their amount. So when they come in and they're already on 80, you just give them 80. But I just want you to understand that IV form is twice as strong. You're actually meeting the goals to overcome and give them more than usual. Does that make sense? Okay. I won't trick you on that. I'll be really quick. I'll be very clear. All right. So now it brings us. We're almost done. Heart failure, normal blood pressure. What do? Bedside ultrasound. Make sure they're fluid overload. If they are, we diurese them. In fact, the quicker we can get diuretics on board and this subclass of patients, the better they do. Somebody said door to loop diuretics in 30 minutes is the goal. Only if they're in volume overload. All right, normotensive, they can still present with all the same symptoms, but their blood pressure is normal. You can diurese them pretty quickly, and it takes only 5 seconds to do a bedside, maybe 10, do a bedside ultrasound with that IVC. Okay? Again, this is just showing you the dose of IV Lasix. Don't get yourselves confused when you leave this room. 40 IV is equal to 80 oral, and we want to give them twice as much. So just keep that in mind. We don't do morphine. Again, no Mona B for heart attacks, and that's the same thing. We don't give morphine for acute heart failure. It causes some issues with ischemia. So if somebody's having a lot of chest pain and you're unable to control their pain with the treatments that you're giving them, like the nitro and stuff, then you can use something that's a little more hemodynamically stable, like fentanyl or something, okay, or IV Tylenol. Try to stay away from morphine and opioids. We don't use ACEs and ARBs acutely for heart failure. In the ER, we use it for chronic management, but not acutely. That's not going to help lower the pressure or anything. All right, that's normotensive. Same with beta blockers. We're not doing ACEs, ARBs, beta blockers if they're normotensive. And then lastly, getting to the last bucket, hypotensive heart failure. They're in cardiogenic shock. What do? IVO2 monitor, airway, breathing, circulation. How do we support their circulation? Low fluid bolus while we're mixing up our pressor. Okay? Just totally foreign or different than what you've been taught before? It's along the same line, right? I know you've heard some of this. You might not remember it all. And then we want to call cardiology early, and especially if they're in cardiogenic shock, you need to get them to a cardiologist immediately because they're going to need support. And at BAMC, we have a special coronary care unit, which is a special ICU for cardiac patients. If they're still circling the drain and you have them maxed out on pressors, I've had cardiogenic shock patients on 2 or 3 different pressors all at the same time. If that's the case, you need to start trying to get them into ECMO, or they may need a left ventricular assist device, things like that. Most heart failure exacerbation patients need to be admitted. Even those that turn around right away, a lot of times you got to figure out why they went into heart failure exacerbation, kind of give them a tune-up, reassess their meds, make sure they're optimized, stuff like that will admit them at least a day or 2. All right, admit, high-risk people who don't turn around, almost everybody requires admission. Am I going through this part too quickly? No, it's really easy when most people need to be admitted, right? The disposition's kind of easy. Only send people home that they are coming in because they're like, hey, I ran out of my meds 3 days ago, and then you give them a little Lasix, and they're they're normotensive and Lasix, and they feel 100% better. Those are really just a small subclass of heart failure patients that you can turn around, refill their meds, and get them out, as long as everything's hemodynamically great. Any questions about this? Just want you to know I finished on time, okay? All right, any questions? I know some of that I went through fast, but I know that you guys have had this before. I'm obviously available if you have any questions, or if you need clarifications or anything like that, but does it seem to be easier to go in those 3 buckets and just look at their pressure and address it? I tried to simplify it for you, at least in acute exacerbation management. Remember, you're in ER, PA hat, versus family medicine, chronic management, and that's a lot more complicated for sure. And there's layers to treatments, right? This is just acute management, turn it back around, then we'll let somebody else optimize it. Does that make sense? Any questions about dissection or heart failure management today? No? All right, well, thank you. We'll get you guys out of here then.